Good morning, everyone. I'm Rebecca Zerman with Arkansas Advocates for Children and Families. Thank you so much for joining us. This is an Arkansas Kids Count Coalition event. Arkansas Advocates coordinates the Kids Count Coalition, but it's a membership group of individuals and organizations all around the state of Arkansas dedicated to raising awareness about policy issues impacting children and teaching people how to advocate. We're really excited to have you today for this presentation on ARHOME, the new Medicaid program, Medicaid expansion program in Arkansas. And we're joined by guests from DHS who will be doing a presentation and then taking your questions. I'm going to throw it over in just a minute to my colleague, Loretta Alexander, our health policy director, but first I wanted to go over a few housekeeping items. If you have questions for the presentation today, please use the Q&A feature, not the chat. The Q&A is what we'll be using to track questions. So type those in there and we'll get to as many as we can. And the staff at DHS has said if we can't get to all the questions, they'll we can share them with them afterwards and they'll get responses to those for us. So we really appreciate them for that. Also, we'll share out this recording after the fact. So if you can share it with your colleagues who may not have been able to attend. And we'll also be sharing other information of a follow-up email, including a really exciting story collection project on Medicaid that our health team's working on. And Loretta will be talking about that at the end of this presentation. But we all hope that you'll either participate in that story collection project or share information about that project with your network. So I'm going to throw things over to Loretta. Thank you so much.
Okay, thank you, Rebecca. Rebecca is our Director of Outreach, and she's done a really good job of pulling this presentation together this morning, this webinar together this morning. And thank all of you for joining us. The Arkansas Medicaid program currently serves around 1 million Arkansans. Recently released census data shows that we have a population of 3 million people in Arkansas. So that's 1 out of 3 people in Arkansas receive some form of Medicaid coverage. This includes elders, children, people with disabilities, pregnant women, and adults with low income. Around 300,000 adults with low incomes receive coverage through Medicaid, what we call Medicaid expansion. And that's 1 out of 10 Arkansans. Today we're going to talk about the program that serves those adults with low incomes through the Medicaid expansion waiver or the ARHOME's waiver, which is currently Arkansas Works, but will be changing. Our presenters today are Kendall Rogers, Deputy Chief of Legislative Affairs, and Nell Smith, Assistant Director of Population Health from the Arkansas Department of Human Services. I'm going to turn it over to Nell and Kendall. And as Rebecca said, we will have time for questions after the presentation. And I will let Cassandra Glover, our Health Policy Fellow, will actually talk about the story collection project at the very end. Thank you, Kendall.
Thanks, Loretta. And we do, my name is Kendall. I know it says Nell Smith up there, but we are logged into her account. So she will be taking over after I do a short presentation on what legislation affected Medicaid overall this session. So again, my name is Kendall Rogers. I have been with DHS since October of last year, so fairly new, but I've been in the legislative arena for about 10 years now. And I would say DHS is its own animal because we do handle so much, including 1 million, as you stated, of our state's population. I will note that's a little, it's correct numbers, it's a little high just due to the public health emergency right now, but we do serve, you know, so many Arkansans, and I know you guys work with that as well. So again, I am going to do a little overview. Elizabeth Pittman was on the deck to do this. However, she got called over to the Capitol to testify. So we know how that goes. I got tagged in on it. So Elizabeth wanted me to share briefly with you some changes to the traditional Medicaid program that were made in last session before Nell gets into the ARHOME program. Adults in Medicaid have always had a much more limited benefit package than children. But with the pandemic, as many things was brought to light, One of those would be the access to primary care services that adults may be limited on. So the pandemic made it very clear how important it is to have access to primary care services. In light of that, the legislators, of course, had some ideas, and DHS worked with them to make changes for the adults that we believe can be a positive impact on our clients and the services that will be available to them down the road. A few areas that they concentrated on would be telemedicine, pharmacy, primary care visits, labs, and x-rays. So I'm just going to briefly overview, like I said, at a high level. And if you have questions, they mentioned using the Q&A feature, and we can address those at the end. And if I can't address those, because like I said, I got tagged in, we definitely can get those answers to someone and get them distributed. Okay, so first off, let's talk about telemedicine. Medicaid now allows primary care physicians to establish provider-patient relationships using telemedicine. This change was made during the COVID pandemic, and now starting in fall or winter, that will become a permanent feature that we will service through Medicaid. We also expanded the number of prescriptions clients can get without having to request an extension of benefits from 3 to 6 prescriptions. We also exempted maintenance medications for high blood pressure, high cholesterol, blood disorders, diabetes, or respiratory illness from that number. So they do not have to count against the 6, which I think is all very beneficial for, I would say, monthly maintenance for everyone that is on those prescriptions. We also will be we're looking into more prescription benefits to be more in line with what children are allowed currently. So we're looking at that, and we'll update everyone as soon as we get more descriptions about that. Act 891 changed the limit for lab and x-ray services from $500 total to $500 for lab services and $500 for x-ray services to remove any barriers to prevent screenings. Preventative screenings. And we'll be doing more work to establish a list of health screenings that won't count against those limits as well. And then finally, Medicaid clients now will have 16 primary care visits per year, up from 12. And again, this is just to align with the goal of encouraging clients to access preventative visits and screenings rather than doing something after the fact because they're having to pick and choose when they want to go to the doctor. Again, this is a broad overview. Of course, there are many more details with these, but DHS is excited, DMS is excited to implement these because we do feel like it is better for Arkansans to do some preventative work on themselves. And also just having access to this prescriptions and to the services that they need and get them healthy. And that kind of is a great lead in for ARHOME because that's what we are wanting to do is help get Arkansans healthy. And to do that, we're offering a broader range of services with our Life 360 homes, our maternal, which one of those is maternal homes, which is great for our babies in Arkansas. And if we have healthy babies, we're hoping we'll have a healthier population down the road. So that was brief and quick, but I know we are here to listen about ARHOME. And so I'm going to turn it over to Nell Smith. Appreciate your time. And again, it's nice to e-meet all of you. And if you have any questions, please drop them in the chat or in the Q&A, and we will get those answered. Thank you.
Good morning. I am Nell Smith. I am an assistant director with the Division of Medical Services within DHS, and I oversee Arkansas Works. I've also been with with DHS for only about 4 months, so it's all a new thing for me. But we've also got in the room here some folks that might pipe in as well. Amy Webb, who is our Director of Communications, and Paula Stone, who has just returned to DHS. She couldn't stay away long, and she is going to be providing her guidance and experience and expertise to help us get ARHOME off the ground. But we are excited to be here to discuss the ARHOME program, and that's the Arkansas Health and Opportunity for Me program, which will replace Arkansas Works starting in 2022. We've been developing this program for over a year, and now we're beginning to plan all the critical details of implementation. So there are some things that we have nailed down, some things yet to go. So stay tuned, more to come. But our hope is that you'll work with us as we draft our rules and plan our outreach to ensure that the program effectively meets the needs of the communities that we all serve. Your input is absolutely critical for the success of our program. And at the end of the presentation, we'll provide the link where you can read our waiver plan and provide your suggestions, thoughts, and guidance. And we really strongly welcome all input. We will take all the help we can get. So I'm having trouble moving to the next slide. Okay. So as you probably know, Arkansas Works is our state's Medicaid expansion program, and Loretta mentioned this as well. Arkansas Works is a significant program in Arkansas. It currently covers about 320,000 low-income adults from the ages of 19 to 64. And the current Arkansas Works state law and federal waiver will expire at the end of this year. The Arkansas legislature in the last session passed Act 530, which replaces Arkansas Works with ARHOME and authorizes us to apply for a new 5-year federal waiver. Our Medicaid expansion program started out as the private option, then it became Arkansas Works, and now it will be called ARHOME. Arkansas Works uses Medicaid dollars to buy private health insurance for beneficiaries, and that foundational piece won't change. But we'll be adding a number of new features to address 3 overarching goals. First and foremost, the most important, improve health outcomes among Arkansans. And we're particularly focused in these 4 areas: maternal and infant health, rural health, behavioral health, and chronic disease. And we know the second goal is provide opportunities to help folks out of poverty. We know there's a well-established body of research that there's a clear relationship between poverty and poor health. So this goal is really to provide opportunities to help people move out of poverty through employment, education, and training. And ARHOME is designed to have a laser focus on addressing the social determinants of health to improve health and promote economic independence. So the third goal is to slow the growth of spending for the population enrolled in ARHOME, but while importantly maintaining the financial benefits of coverage through qualified health plans. The qualified health plans, or QHPs, provide higher reimbursement rates to providers in the traditional Medicaid, and that's really important for ensuring the financial stability of our healthcare community. So the primary focus of ARHOME is on health improvement. Despite the gains in the rates of individual insurance coverage that's come with Medicaid expansion, Arkansas continues to struggle to improve its rankings for measuring health outcomes. According to the most recently released America's Health Rankings annual report, Arkansas ranks 48th overall among the states. And we want to make sure that ARHOME is more than just about providing healthcare coverage. So one of the changes with ARHOME is that we believe will lead to health improvement is holding QHPs accountable, the qualified health plans accountable for the care that their members receive. So we'll use quality metrics from the adult core set to determine how QHPs are doing now in terms of their members getting preventive screenings and needed medical treatment. And we'll set performance goals that they'll be required to meet. This is the first time in the life of Arkansas's 8-year expansion program where we've held QHPs accountable for meeting annual health targets. So the annual improvement in health quality measures include we have multiple measures in these 4 areas: primary care, access and preventive care, maternal and perinatal health, care of acute and chronic conditions, and behavioral health care. And we'll use those financial penalties to ensure that the QHPs really work to meet those target metrics. So the health plans will provide incentives to their members to participate in health improvement activities. For example, they might provide a Walmart gift card to members who get their annual flu shot, or they might waive members' small premiums for women who get a mammogram if appropriate. And health plans will be required to submit annual quality assessment and performance improvement strategic plans. Those plans will describe how they're going to engage with their members, how they're going to engage with providers, and what their role is going to be in expanding access to behavioral health providers. We want to ensure that QHPs are doing their part to help meet the needs of individuals with mental health or substance use issues. So a major additional feature in our home program is what we're calling the Life 360 homes. So these are sort of programs within the larger Our Home program. We'll partner with hospitals to provide additional support services for the populations that I mentioned earlier that are a focus for Our Home. So pregnant women, particularly those with high-risk pregnancies, individuals in rural areas with behavioral health needs, young adults who are most at risk of long-term poverty. So we're planning these three types of Life 360 homes, and I'll describe each one a little later. The maternal Life 360 home, rural Life 360 homes, and Success Life 360 homes. So the first Life 360 home is Maternal Life 360 home. And why are we focused on pregnant women and their babies? And that's because Arkansas ranks 49th in the nation in maternal and infant health outcomes. Each year, Medicaid spends more than $100 million to pay for NICU stays for about 2,100 babies, and more than $44 million for the deliveries of low birth weight babies. So we'd like to reduce the number of babies who suffer the lifelong consequences that can come with beginning life in the NICU, as well as the high cost of that treatment. In 2019, over 15,000 Arkansas Works enrollees were pregnant, with over 11,000 births that year, and 34% of those had high-risk pregnancy. So how will the Maternal Life 360 home address those issues? We'll contract with birthing hospitals, those with an obstetrics unit that want to participate. The hospital will provide evidence-based home visitation services for women with high-risk pregnancies. The participating hospitals will either employ their own staff or work with a partner organization such as Early Head Start to provide a home visitation program for pregnancy as early on in the pregnancy as possible through the baby's first 24 months of life. The woman's doctor will continue to provide all medical services as he or she does now, but will refer the pregnant woman for these additional home visiting services. So the goal is for all women in our home with a high-risk pregnancy to receive these services no matter where they live in Arkansas. And we think about 5,000 women will be eligible annually. So this slide shows the Arkansas Works enrollment across the state as a percentage of the population in each county. And while the highest numbers of Arkansas Works enrollees are in the urban population centers, our rural areas, the Delta region and the northern part of the state have some of the highest proportions of Arkansas Works enrollees. In some counties, nearly a third of residents are on Arkansas Works. 40% of Arkansans live in rural communities, and that's important for the health of our state because we know that rural communities often have less access to healthcare services, higher rates of chronic disease and behavioral health issues, and higher rates of death. So because of those statistics, we consider stabilizing and strengthening healthcare in our rural communities to be a major aim of the Our Home program. And we're creating the Rural Life 360 homes to address that. So we'll contract with critical access hospitals and small rural hospitals to screen and refer all Arkansans for health-related social needs. We'll offer acute crisis unit services, including just-in-time acute crisis beds for clients in crisis with mental illness, substance use disorder, and substance use disorder. This expands the services that are now provided by the crisis stabilization units that we have in the state so far. and these services will be available in hospitals in rural areas in the state. The Rural Life 360 homes will employ coaches or peer counselors to work with individuals with serious mental illness or substance use disorder. These coaches will provide care coordination services, and you can see from the definition that we're taking for that we have for care coordination that we're taking a broad approach to care coordination. So it can include screenings and assessing an individual's health-related social needs, developing person-centered support plan, coordination of medical and non-medical providers, and an effective communication with clients. Medical care will still be provided by individuals' local physician or therapist, and these care coordination services are in addition to the medical services that individuals already receive and that their QHP already pays for. So there's no financial risk for the hospitals choosing to become a Rural Life 360 home. We'll provide startup costs to the hospitals that choose to become a Rural Life 360 home to make sure they have the financial backing to ramp up services. And we'll provide funding to strengthen rural emergency response with crisis training and telemedicine equipment deployed. Success Life 360 home. And this program will serve groups of young adults who are most at risk of long-term poverty. So first we have veterans ages 19 to 30, and we estimate that we have about 14,500 veterans enrolled in Arkansas Works. And in part because of Arkansas Works, our state has had the second highest reduction nationally in uninsured veterans after the Medicaid expansion was implemented. We know this population has higher rates of certain health conditions. More than half of veterans enrolled in Medicaid have a disability. 42% have 2 or more chronic conditions, and more than 10% have been diagnosed with a serious mental illness or a substance use disorder. And over 10% of Arkansas's homeless population are veterans. The next group is adults formerly in foster care. These are individuals aged 19 to 27. Nearly 4,500 Arkansas Works enrollees between the ages of 19 and 27 have been in Arkansas foster care at some point in their lives. Statistically, those young adults have a higher chance of being homeless, becoming pregnant as a teenager, suffering from behavioral health issues, and being unemployed or not going to college. The next group that we're hoping to address in the Success Life 360 home are those individuals who were formerly in the Division of Youth Services custody, ages 19 to 24. A little over 2,500 Arkansas Works employees were previously in DYS custody. And we also know that the individuals with experience in DYS are some of the same individuals with experience in our adult correctional system or in foster care. 44% of our Arkansas Works enrollees who spent time in DYS custody were also incarcerated as adults. Nearly a quarter of individuals ages 19 to 24 who were in DYS custody were also in foster care. And the fourth group that we're hoping to include in the Success Life 360 home are the formerly incarcerated young adults ages 19 to 24. Nearly 18,000 Arkansas Works enrollees were formerly incarcerated. The individuals ages 18 to 24 have the highest rates of recidivism, and that's 68% for males, 50% for females. And the annual cost of incarceration in our state is about $23,000 per person. And we know that that state cost is in addition to the human cost of incarceration. So we want our home through the Success Life 360 homes to help address the challenges that these groups of young adults face as an outgrowth of the experience in their youth. So as with the other Life 360 homes, we'll contract with hospitals, acute care hospitals, that would like to become Success Life 360 homes. And the hospitals will partner with an experienced community service organization such as Goodwill or Our House to provide intensive support to help address the health-related social needs that these young adults face, including helping connect them with work and educational opportunities. Young adults served by the Life 360 homes will be referred to to services by their medical provider. And as with the other Life 360 homes, the medical services will continue to be offered, that these folks receive will continue to be offered by medical providers and covered by their QHP. The Life 360 home services are additional services beyond what's already provided through the healthcare system. So for the hospitals that choose to become a Life 360 home, we'll provide one-time funding to assist with startup costs, and we'll pay monthly per client payments that the Success Life 360 home hospital will share with its strategic partner. And finally, we'll offer financial incentives for the Success Life 360 homes and their partner organizations when clients meet work and education goals, or when the services result in a reduction in recidivism rates. So now I want to zoom out and provide the big picture on how ARHOME impacts Arkansas financially. The federal government pays 90% of the cost of Arkansas Works, and will continue to do the same for ARHOME. And you may know that not all individuals in Arkansas Works are in a qualified health plan. For example, individuals who are considered medically frail are on the traditional fee-for-service Medicaid. But 84% of our Arkansas Works enrollees are in a QHP through private health insurance. And these plans pay hospitals and other medical providers commercial rates, which are higher than what the healthcare providers get for populations enrolled in fee-for-service Medicaid. What that means is we're using 90% of federal match dollars to pay our struggling rural providers those higher commercial rates. And the additional funding and revenues are, of course, vital to the state economy and our healthcare infrastructure, especially for our rural hospitals. Over the past decade, 56 rural hospitals closed in neighboring states, while only one rural hospital closed in Arkansas. And I'll show you what that looks like on the next slide. But 60% of our rural hospitals are still considered at risk of closing. So this slide shows the impact of Arkansas Works on our state's rural hospitals. Each of those little X's represents a rural hospital that is closed since 2012. And you can see the significant blank spot in the middle for Arkansas. We've just had one rural hospital close since 2012, while our surrounding states collectively have had 56 rural hospital closures, clearly demonstrating the impact that Medicaid expansion and our high reimbursement rates through Arkansas Works have had on the financial stability of our healthcare community. So one important new feature with ARHOME is the creation of an oversight panel. Act 530 includes a new joint executive legislative oversight panel to monitor and guide our work. You can see that the varied membership of the panel on the slide includes individuals representing healthcare constituencies, as well as leaders in workforce and education. This panel will meet quarterly, and one of its primary purposes is to review the QHP's annual strategic plans for improving the health of their members. The panel will review performance metrics for each QHP, measuring the extent to which their members are receiving preventive screenings and appropriate medical care. And performance on those metrics will be broken out by race and ethnicity, as well as by urban and rural areas. Setting the targets each year for performance improvement will be a public process, and the QHPs can face sanctions if they fail to meet the targets that are set for them. So this is the first slide of two that we have for the implementation timeline. On Sunday, June 13th, we put our waiver out for state public comment, and you can see I've provided the link there. Please go there, please read it, please provide any additional suggestions, critiques, anything. We'll take all of the input that we can get. We will have two public hearings. The first one is set for June 21st, and the second one is June 22nd. The details of those public hearings is also included at that link, so you can find out where you can go to participate in those public hearings. They're both going to be held over Zoom, so you can attend from the comfort of your own home. July 12th is the deadline for the end of the state public comments, and July 14th then is when we plan to submit our waiver to CMS for review. In August, we will start up our first meeting of the advisory panel that I mentioned earlier. At that first meeting, we will be presenting baseline performance metrics. So metrics that, is where everybody is starting from. And the health plans will be there to discuss their strategic plans for ensuring that they meet the target metrics that we'll be setting for them. Also in August, we plan to submit our ARHOME related rules and manuals out for public comment. By November, December, we hope to have CMS approval for the plan and plan to bring in November or December the ARHOME related rules and manuals for legislative review and approval. In December, we will have our second meeting of the advisory panel, and that is where we intend to set the health metrics performance goals for 2022. And also in December, the health plans and the state will finalize the MOUs. These are MOUs that we established with the health plans to describe their requirements and what they're obligated to do under the plan. And January 1, 2022, ARHOME begins. This is our contact information. Elizabeth Pittman has arrived from her time spent at Legislative Committee this morning. So she is also here. She is our director of the Division of Medical Services. So feel free to email either one of us or any and all of us. We'll all accept it. And that's the end of what I have prepared. And we will all be happy to take questions.
Thank you, Nell, for such a detailed presentation. So the first question is there a model in practice for the waiver changes? If not, what studies informed the waiver?
We had a variety of studies that informed the waiver, which are described throughout. Because the waiver is so varied, I think it's maybe too much to mention, but it is all described in the waiver.
Thank you. So the second question is, how is experience defined for community bridge organizations? And there are service gaps in rural Arkansas that could limit the partnership pool.
I'm sorry, can you say that again?
It says, how is experience defined for the community bridge organizations? There's service gaps in rural Arkansas that could limit the partnership pool.
Yes, we are in the process right now in drafting the rules of determining those kinds of issues. What sort of background does an organization have to have? And we certainly want to, while we want to make sure that we're ensuring that partners have some experience and know what they're doing, we also want to make sure that we are spreading services across the state as much as possible. So it's a fine balance, but those are decisions that we will be determining as we draft rules.
Okay, thank you. The next question is, what is the likelihood that CMS will not approve the waiver?
We don't think that CMS is going to deny the waiver at all. We think that there will be components that we may negotiate with them. They may want some changes. But we think that it's not a yes or no. It's working through details. But we also are aware that we believe that CMS there's much in our waiver for CMS that CMS is going to be really excited about and pleased with.
Next question, will the peer counselors mentioned in the waiver from Maternal Life 360 homes be providing evidence-based services? It says, curious as a similar term was used for peer counselors in the Rural Life 360 effort, which may not be evidence-based.
Yes, our intent for all of it is to be as evidence-based as possible. And the exact nature of that is still, we're still working through the details of, but we want to make sure that that the folks that are being selected to work with our clients are as capable of making change as possible. So yes, we will, evidence-based is a very important component in our plan.
Thank you. And I just want to make a quick reminder that this session, this webinar is actually being recorded. So for those of you that may not be able to get all the questions, the answers written down or whatever for the questions, you will be able to go back and revisit the webinar later on, because we are recording it. Next question is, will our Marshallese populations be able to use these resources?
We hope to make sure that we are including as much, as many resources and ability for diverse populations to be served. And again, I believe some of those will,
Froze now. Can you hear me?
And Marshallese, and we have been working with the Marshallese Coalition and others and Arkansas advocates actually to make sure we're reaching the Marshallese population as it relates to Medicaid and the services that are now available to them. So that is a priority for the department, and very good question. Thanks for asking that.
Thank you. The waiver mentions ARHOME eligible individuals with severe mental illness or substance use disorder going into the passes. What will happen for pregnant women with severe mental illness and or substance use disorder? Will they still be able to receive the support of the Maternal Life 360 homes?
Hi, I'm Paula Stone. Wanted to talk about the answer to that question. And so, as Nell said earlier, the services, the medical services, which substance abuse and mental health medical services are still delivered by providers in the community and paid through the QHPs.
Okay. Next question is, go ahead.
And so for the maternal, if they're in the maternal home, they're going to get some level of care coordination through their home visiting. And so those services would be coordinated through the Life 360 maternal home and delivered by a provider in the area. So that would be something that would be coordinated there, and then the delivery of those services and the access to the services are in the community. So they would be able to get those services and have them coordinated.
Next question says, how many QHPs are there?
there are two carriers, Centene and Blue Cross, and there are 5 plans among those 2 carriers. And we can, that it's not limited, if another QHP wanted to become an Arkansas Works carrier, they would just go through the process to become one.
Will these changes affect the federal poverty level that determines eligibility of individuals?
No, and nothing about this is changing the eligibility for Arkansas Works at all. The income limit is 138% of FPL for federal poverty level, and that will remain the case under ARHOME.
How do we link community-based organizations that help in social determinants of health, with health, human and social services across the state currently?
How do we connect them?
It says, how do we link community-based organizations that help in social determinants of health with health, human, and social services across the state? How do we currently do that?
I think that's probably a wide range of ways that are connected. I can tell you that what we would like, if we would like to be connected with those services, and we'll reach out to all of the services available.
Hi, as you guys know, DHS is a large umbrella agency, so we have more than Medicaid, and we do, and depending on the division, they do work closely with community-based organizations all across the state to address different issues. I'm thinking, for example, our Division of County Operations, particularly right now with COVID, for example, they're working with a rent relief program. And we have connected with over 100 community organizations across the state to help share information about the rent relief program. And we also have many organizations that are actually either helping people apply or helping them with resources. And we all know that housing stability is a key factor in terms of social determinants of health. And so we depend on our community organizations. We know we cannot do this alone, regardless of what program it is for DHS. We work closely with community organizations for the child welfare system, for our juvenile justice system. So we are, we believe it's important to have those partnerships, and we hope to grow those partnerships, and they will be just as important in our home as they are in other areas. I hope I answered that question.
Thank you. Someone said state the acronym CMS.
Someone says what?
CMS is the Centers for Medicare and Medicaid.
Oh, DMS is Division of Medical Services.
Oh, they said CMS.
Oh, CMS. Oh, yes, Centers for Medicare Services.
Okay. Next question. It says, I'm seeing that most of the questions address adults except for the maternal child programs that provide interventions that are prenatal and up to 2 years of age. Concerned that we don't have current capacity for these moms. How much will Medicaid pay for these services? If inadequate, there will be skimping on service models.
Sure. And I'll just say that the ARHOME is the program for adults, and Elizabeth, who is our director of medical services, will address children.
Is the question on here so I can make sure I catch all of it?
Okay.
Okay. So yes, so the Arkansas Works, which will turn into ARHOME, covers our adult expansion population. So 18 through 64. Currently, there are two ways we cover pregnant women in Medicaid. It's through Arkansas Works. If they come in prior to being pregnant and they qualify for Medicaid, they go into Arkansas Works, which will be our home. We do not remove them from their QHP if they become pregnant. We leave them in that plan so they have continuity of care during that pregnancy. They will continue to receive those services. The QHPs are required to provide maternal services. They will then also be able to access the Maternal Life 360 under our home. We also provide services to pregnant women through Medicaid that do not qualify for Arkansas Works or who come to Medicaid pregnant through Pregnant Women Medicaid. And so they receive comprehensive maternal and obstetrical services through that program. Does that answer the question?
Not sure.
And the service, that's, I mean, there will not be any skimping on services. They will continue to receive the same services that they receive through Medicaid.
I guess the question is a lack of capacity now, and what will expand the capacity as we go forward?
Well, I got you on that one. We are continuing to work to expand capacity across Medicaid with all provider types. Part of what we're doing with the Life Maternal Life 360 Homes, sorry, tongue twister, is trying to bring in critical access hospitals to expand that capacity. We also work with community partners that are looking at expanding capacity and how can Medicaid assist in that. So we're always looking for those community partners that are working to expand capacity and hospitals that are looking to do that across the state and trying to partner with them.
Thank you. Next question says there is acknowledgement that Medicaid doesn't pay adequate compensation for rural care relative to the private market. There is no less an issue for urban and suburban practices. Any plans to address this issue to ensure access to care for Medicaid subjects?
So we continually assess Medicaid rates to that question. We currently are under an executive order from the governor to look at all Medicaid rates. We just recently increased primary care provider rates by a total of 8%, initially a 5% and then a 3% rate increase. We continue to work with FQHCs on their models and how we can access care. We're looking at telemedicine as ways to increase access in rural areas. So we continually look at those issues and try to address those as a Medicaid agency.
The next question, how will community bridge partners be selected? By RFP, by contract, or by general application?
There will be an application process that, again, we are working through as we draft rules right now. But we anticipate that it's a voluntary program. They can choose to participate. We're hoping to make it something that they want to participate in. And we will create an extensive application process to ensure that we've got folks who are hospitals that are ready to go when the Life 360 homes kick off.
Thank you. So we have one last question. I'm not sure what it means, but it says Paula Stone, is she the Arkansas SSA? No idea what that means.
Is that the single state authority?
I'm not sure what SSA means. Can someone explain to me?
I'm not either. So it's just a question that's typed in.
Paula is here working with us to do the rural Life 360s. So that's her role here with DHS.
Okay. Well, I have a question. You mentioned for the Life 360 for rural areas and community service organizations, you mentioned Our House as an example. So what about those rural areas that don't have the type of services in their communities that are in Central Arkansas, like Our House?
We hope we can find rural areas that have those sorts of partners. I think that is one area that we want to make sure that we are expanding those types of organizations throughout the state, and hope that eventually these programs can build capacity in that area. But that will be an issue as we go forward, making sure that we've got good partnerships for the rural areas for the Success Life 360 homes.
Another question that I have regarding the home visiting model is that you mentioned Early Head Start in there. Does Early Head Start currently do home visits, or will that be something that's as an add-on to their programs?
They do, yes.
Any other questions from our participants? Okay, there's another question that says single state authority. Is that Paula Stone or someone else?
So if you mean by single state authority, the single state Medicaid agency, no, that's not Paula, that's DMS.
Are they asking that? Is it a SAMHSA question?
I don't know. Is it a SAMHSA question? DMS, in my world, single state authority is the state Medicaid agency, and that's me, or DMS, not me personally, but Division of Medical Services.
Yeah, okay, got it now. I wasn't sure either, so I couldn't answer.
And I don't believe she is for SAMHSA either, are you? She's not the single state authority under SAMHSA either.
Okay, next, someone says, please keep in mind that the bridge partner process is an equity and access issue. Minority-owned providers may not have capacity to complete extensive applications, but are nonetheless effective.
Thank you. We take that under advisement. We, like I said earlier, we want to make sure that we're balancing individuals that have demonstrated effectiveness, but we also want to make sure that we are providing access to these special services throughout the state.
Thank you. Next question says the waiver mentions strong start for home visiting. Would that be a preferred model? How will that expansion be supported as a relatively new model to the state?
We right now we're writing the rules about what sorts of organizations the hospitals will need to partner with. So right now we're open. We want to make sure that again we've got effective models that we're working with, but we're also interested in promising models as well. But those are details that we're working through as we determine what's an eligible organization.
Thank you. Next question, how can rural hospitals get involved and enroll in programs?
Well, for one thing, I will say that we will need all the rural hospitals' help that we can get as we draft the rules. So we'll need their input. So on the front end, we'll take all the input that we can get. We may be coming to rural hospitals and knocking on doors and asking for help as we develop the rules. But once we have that in place, reach out to us, get involved and apply to become a Rural Life 360 home.
Thank you. Well, I want to thank our presenters so much in DHS for coming on and sharing this information with us. And if you could go back to that slide, to the last two slides with the dates on them, Nell, if you could, that have the calendar of activities. So I think it's like 13 and 14 maybe.
Oh, the timeline, did you say?
Yeah. Just kind of to remind people that you know what the dates are for the public hearings, and also remind people that if you have any public comments, you can send those comments in writing to DHS. And did you put up is this the URL? Is this where the actual application is for this?
Yes, that's where the application is. That is where the email address to submit your comments, and it also has all of the information about the public hearings.
Okay. Can you are you able to put that email address? I mean, this URL address into the chat now, so that people can actually click on it and get it up on their own computers.
Sure.
Thank you. Thank you. Okay, so we have no more questions that I can, well, it looks like there's one more. Let me see what that is. Changes to ARKids A or B. Will this include changes to ARKids A or B?
No, this program, ARHOME, will not include changes to ARKids A or B.
Okay, so to all the participants, if you look in your chat, we just put the link so you can go and actually read the application for yourself and be able to submit your comments. Any you want to write a letter, or if you want to go to the hearings, the public hearings on next week, I think. And understand that we have 30 days to get comments in and share this information with your colleagues or organizations that have questions. Submit them to DHS. Again, thank the presenters for coming to us. And now Cassandra Glover from Arkansas Advocates will quickly share a project that we're working on regarding story collection for Medicaid.
Hello, everyone. I want to inform you about a project that we're working on. Arkansas Advocates for Children and Families is currently collecting stories about people's experiences with Medicaid. We want to know how Medicaid has impacted individuals and their loved ones. So we're asking people whether they've been beneficiary of Medicaid, or maybe they were even denied services through Medicaid, to share their experiences, as well as providers who service people who receive Medicaid services. In the chat right now, I will drop article that we have on our website discussing the storytelling project and how individuals can share their stories. We're asking you if you yourself may be a beneficiary of Medicaid or know someone who's on Medicaid or had an experience, positive or negative, to share this link with them and allow them to share their story. All participants will receive a $50 Visa gift card for sharing their story. So thank you, and that's it.
Thank you, Cassandra. And I do want to reiterate what she said. And not only, it's not limited to beneficiaries or providers. It can be community organizations. If you serve people that actually are on Medicaid or receive Medicaid or have received Medicaid, we're just interested in getting a broad range of experience from different perspectives to create a story bank of information regarding Medicaid services here in Arkansas to help us inform our advocacy efforts. And again, thank you all for attending. Thank you, DHS. Thank you to Rebecca for coordinating everything for us. And if you have more questions or whatever, just please send them to us. It says, do participants have to be current recipients of Medicaid? It doesn't matter. If you have any lived experience with Medicaid, it can be a family member, it can be you, it can be, if you work with an organization and help people get Medicaid, it does not matter. It's an experience with Medicaid. So thank you all again for attending, and certainly thank you to the presenters, and please pay attention to the next developments for the ARHOME Medicaid waiver application, and as we go through this process.